Thank you very much. Um, Thank you, everyone, and good afternoon. My name is James Villar-Mead. I'm a PhD candidate in biomedical engineering at the University of Minnesota's Visible Heart Laboratories. And today I'm going to be discussing with everyone pulse field ablation-induced hemolysis. So here are my disclosures. So hemolysis is the destruction of red blood cells. Commonly, when mild hemolysis occurs, there's a scavenging protein, haptoglobin, that binds to the hemoglobin and then is subsequently cleared by the liver. But in more severe instances, that free hemoglobin depletes the haptoglobin, and then the free hemoglobin actually circulates unbounded. So let's follow like a red blood cell through the heart during a procedure such as this. So you have a red blood cell that passes in the heart where an ablation is occurring. And during that ablation, there's a pulse electric field. That red blood cell passes through that electric field, and if it reaches a specific threshold, then it causes hemolysis. And in more severe instances, like I mentioned, the free haptoglobin is depleted. So then that free hemoglobin actually makes its way to the kidneys and causes direct damage to the kidneys, leading to acute tubular necrosis, and can potentially lead to acute kidney injury as well, and other urinalysis aspects like hemoglobinuria, oliguria, and muddy brown casts for indications. So this can actually be visualized by centrifuging blood down. So you have your plasma, your buffy coat, and your hematocrit. And with increasing ablations, you can actually visualize this across like here visually, and kind of make indications off of this hemolysis like reference palette. So you can actually just visually do it if you don't have a spectrophotometer handy. So why do we care? Hemolysis has different indications for patients. You guys could tell me more so than me telling you, but across like different aspects and depending on how severe the hemolysis is, there's severe like fatigue, nausea, shortness of breath potentially, and then the acute kidney injury can lead to some sort of pain. And this has been studied in the Ferropulse Manifest study, which was a large retrospective observational registry. So there was around 17,000 patients, but 5 of them all had persistent atrial fibrillation and complex lesion sets that, as you can see here, had increased creatinine levels due to the number of ablations here. And they each required like hemodialysis and hospitalization for all of these patients. Similarly, Vanier had 2 patients that he used as an indication. So he decided to do a single-centered cohort study with 68 patients where they did all of their ablations, and then they didn't find any acute kidney injury. But an interesting thing that they came up with was around 70 pulse field ablations, depending on their catheter used, which was the FARAWAVE, was relatively safe, and up to 100, which was more indicative of hemolysis occurring. And even though there were no acute kidney injuries in this case, there was 24 patients still that showed some signs of hemolysis. And yeah, so I had mentioned they utilized the FARAWAVE catheter, and what's difficult is like nobody knows how each of these catheters portray across because they each have their own complex electric fields, and it's kind of hard to generalize the findings here. So that leads me to like kind of factors that contribute to hemolysis. As I mentioned, like kind of the catheter conformation, so the field distribution, electrogeometry and tissue contact, the actual waveform parameters being utilized, and number of applications all play a role. So it's a balancing act between each of these aspects to have less hemolysis or a less deep lesion versus potentially more hemolysis or less or a more deep lesion. And there's a lot of electrophysiologists in this room, so everyone's kind of familiar with an RV map here. But utilizing the visible heart apparatus, we're actually able to kind of visualize the complexity that goes along with this RV shell. And it highlights the need for understanding of what's happening in this complex geometry. So like whether your catheter is in full contact, I know they have like force sensing and impedance measurements, but even though like if you're in contact to a certain extent, the other half of your catheter is still, the electric field is still being shunted into the blood, causing some form of hemolysis. So it's important to understand this. So the second aspect was the waveform parameters. Commonly, clinically, the microseconds and nanoseconds are being utilized. But it's important to kind of understand, like from a biomedical engineering standpoint, like what this actual waveform is. So like you have your positive voltage amplitude, your positive pulse width, your interphase delay, your negative pulse voltage amplitudes, and your negative pulse widths, and your interphase delay. So all these play a role, and becomes quite complex because this is just one pulse. So you can actually change a lot of these things. How many pulses you're giving, how many pulse trains you're giving, and ultimately you can also change like the waveform. So all these things actually play a role into what's being designed for the cath lab. And with a partnership with Matej Rebersek, he actually founded a company that allows us to actually manipulate all these parameters I'm mentioning. And that's what I'm going to be investigating. And it's going to be mostly square waves that I'm looking into. So integrating the three hemolysis factors that I mentioned, so the field distribution, electrogeometry, and tissue contact, the PFA waveform parameters, and number of applications, in collaboration with the Visible Heart Laboratory and Medtronic, we actually, utilizing the LPOR system, kind of came up with 3 different waveforms to kind of study. So we ended up going all the way down to 500 nanosecond pulse widths for these biphasic waveforms. So like there's a 500 nanoseconds and 500 nanoseconds, and then 2 microseconds and 8 microseconds. We chose this because they're like 4 times separated, so we can actually visualize the difference between these. The second aspect is we designed a common 252 catheter that is utilized in the cath lab, and then we ended up making configuration in a parallel form. So like they're 1 centimeter apart, so we can actually control what's occurring with the electric field. And then we delivered these into homogenized bovine blood. So, and at each of those aspects and waveforms, we actually did serial draws. So at 0, 2, 4, 8, and 16 applications at each of these waveforms, we ended up pulling blood out and then centrifuging it, like I mentioned earlier. So you can see kind of the spread here of at each of these waveforms. So 500 nanoseconds, you'd expect less hemolysis, which you do see here, and then 2 and then 8 microseconds having the most, which isn't commonly utilized. But then again, it's balancing the hemolysis versus actually the lesion formation, because the more narrow your waveform, the more voltage you're gonna have to push to actually create a deeper lesion. And on the right-hand side, so I utilized 6 different animals, so there's variability here, but you can see the R-squared value and the linear aspect for each of them. And as you can see, visually as well as spectrophotometry, that the 500 is the least, second highest is the 2 microseconds, and the most is 8 microseconds. So the goal here is to actually come full circle with what Veneer was discussing, that these catheters, we don't know how they interplay with each other. Like, so one catheter can't be read into another's results. So with this controllable waveform aspect here, starting with our parallel bipolar electrode configuration, we're doing some electric field modeling so you can understand the actual like distribution of the electric field around the bipolar electrode to kind of see what surface area is actually affecting the red blood cells. And the next steps here is going to be to kind of create a transfer function to kind of hopefully predict hemolysis values that are going to be occurring at each of these different catheter form factors. So the translational impact and next steps here is going to be to optimize, for translational impact, is going to be optimize ablation catheter design and kind of create safer and more effective PFA waveforms, understand the mechanism of blood component injury at each of these aspects, and kind of create this predictive model for increased patient safety. And so the next steps is going to be to have a greater sample size, investigate more waveforms, like I mentioned. There's quite a few to kind of play around with the LPOR system, test other blood components like white blood cells and platelets, which could potentially be helpful to clinicians, and ultimately test this with human blood in this in vitro setup. So in summary, I discussed what PFA-induced hemolysis was, importance of this topic for patient well-being, PFA factors that contribute to hemolysis, and in vitro experiment testing varying PFA factors, and designing a transfer function. Thank you, and I'll take any questions.